Some of what I'm going to say follows a little bit along from Professor Dunlop's talk about this issue of can we prevent the secondary injury to spinal cord tissue after blunt trauma. And that's really the point of the risk study that I'm going to talk about. Plus also I'll explain to you the journey that was needed to establish this project in Australia, which is part of an international collaboration. So I'm hoping I'll get my buttons right here. Yep. So you can see that there's a number of institutions involved in setting up and running the Riluzole in spinal cord injury study, or RISCUS for short. There's my hospital, Prince of Wales, but also Royal North Shore, who we partner with in Sydney, and more recently the Royal Adelaide Hospital here with Professor Brian Freeman. But the central organisation that's sponsoring this worldwide is AO Spine in North America, and we have used the Neuroscience Research Australia group in Sydney to be our umbrella organisation within Australia, and they have the link with AO Spine in North America. And we have Royal Rehab in Sydney, which does a lot of the rehabilitation phase for spinal cord injury. Of course, we're working with the New South Wales Health in Sydney, and actually the Spinal Cord Injury Network was very important in helping getting this project running. So the Riluzole study is the fruit of the work by Professor Michael Fehlings in Toronto in Canada, who performed the animal studies using Riluzole and has embarked on this worldwide project to do a randomised controlled trial of the possible benefits of Riluzole in acute spinal cord injury. So really this is his work that we're carrying on. So after an acute spinal cord injury, we have no real way of repairing the damaged tissue. So there are various strategies we can use. The natural recovery after such an injury is very modest. If the initial injury to the spinal cord is complete, as in no function at all below the level of injury at the time of presentation to hospital, then a small number of people will improve to some extent, and 5% might achieve some useful additional motor function, perhaps a segment or two in their upper limbs. If the spinal cord injury is incomplete initially, then there's a better chance of some improvement, as you can see the figures there. But still, this really represents sort of regional improvements within the body systems rather than a major recovery to restoration of normal function. So this is to repeat Professor Dunlop's concept that there's a central area of trauma damaged tissue that cannot be retrieved, but there's that penumbra in the blue here which we might be able to retrieve with appropriate treatment. And there's a cascade of cellular events that leads to the damage of that tissue, all around inflammation, impairment of blood flow, and breakdown of cell membranes. And importantly, a part of that is what ionic balance, influx of sodium ions into cells, and the excitotoxicity of a locally released neurotransmitter glutamate. So this is just to demonstrate the mechanism of sodium ions entering into the cells on the right-hand side, and the cells build up into the model of the spinal cord. So influx of sodium ions will lead to cell damage through changes in acid-base balance, swelling of the cell, changes in calcium concentration, and triggering the release of glutamate, all of which will lead to cell death in a cell which otherwise was living following the injury. So Riluzole is not a new drug, although this use is new for the drug. It came around in the 1980s, was a designer drug for epilepsy, which never really worked out very well. And this means that the manufacturer or the originator of Riluzole is not interested in sponsoring research into its use because their patent has run out or is about to run out, so they would not recoup their investment. But Riluzole is in fact a sodium channel blocker and is anti-glutamate. So theoretically it has potential benefits in spinal cord injury. And as I mentioned, that's been demonstrated to some extent in animal models, including by Professor Fehlings. His model was to squeeze spinal cord injury, spinal cord of rats, and see if they could walk again afterwards. It has been said somewhat pessimistically that it's too easy to make rats walk again, and these experiments abound, but nevertheless there were some statistically beneficial effects of administering riluzole to these spinal cord injured rats. And if I use the mouse. So the top line, of course, is riluzole. And so the BBB is a sort of paralysis score of rats. And as time goes by week, the paralysis in the treated rats improves to a greater extent. And then this is being able to walk up a slope. And again, the riluzole-treated rats achieved their slope walking milestones at an earlier stage than their non-treated rats. And in those same animals, we can see there's a greater degree of tissue preservation within the spinal cord compared with the controls. And here it's greatest at the epicenter of trauma. The riluzole-treated rats have a greater retention of normal tissue or living tissue. In humans, riluzole was used in a pilot study 4 or 5 years ago in a small group of patients who were given this drug, and it's an oral administration for 2 weeks, starting within 12 hours of their spinal cord injury. And that was, they were then followed for 6 months, determining their motor function. The only controls were historical controls from a database, so this is not a randomised trial, it was just a pilot study. So the results are somewhat tantalising. If you group the more severe types of spinal cord injury and follow them over time, this is days out here, then these are the riluzole-treated patients compared with their registry controls. And they're fairly similar, with a slight improvement on the riluzole side, but we can't say that that's statistically significant. If you separate these out into the AISAs, or complete injuries, there's still a little difference between them. But the B, which is where there's some sensory preservation, there appears to be a more significant benefit from the use of riluzole, but it's not seen in C. So this is a bit messy data, nothing very clear-cut. But this, combined with the animal studies, is tantalising to suggest the possibility of some benefit of the use of riluzole. So, on the other hand, we can say there's equipoise about the use of riluzole. We don't know for sure. So it's appropriate for it to be used in a randomised trial where you have to ask a potential participant, would they like this or not? And we can say, when they say to us, well, what do you think? We can say, we don't know. Really don't know whether this is going to be good or bad. Well, I shouldn't say bad, good or not good. Therefore, it's reasonable to flip a coin as to whether you get it or not. And that's important when you're actually trying to run a randomised clinical trial in which people are being asked to give their consent. We can reassure the potential participants that riluzole has a safe clinical track record. It is actually used currently for the end stages of motor neurone disease, in which it can prolong ventilator-free days towards the end of life. But its prescription is restricted to specialists only. A neurologist has to prescribe it. And we found that the only real adverse event in clinical practice is a rise in liver enzymes, which is rarely symptomatic and is rapidly reversed once riluzole is ceased. So it's not a particularly dangerous drug. Therefore, it's reasonable, again, to offer it in a randomised clinical trial. So the trial that Professor Fehlings has set up is international, so it's now international and it's multi-centre. It's been determined that we require 365 participants in the study. It's going to be randomised, of course, where the actual administration of the drug is unknown to the patient, the nurse, the doctor, the research assistant. The only people who know ultimately are those back in control, back at AO Spine, North America. Placebo-controlled, where the blank tablet looks identical to the real tablet. and it's double-blind because neither the patient nor the doctor knows, which is the best kind of study, of course, because from that we, in theory, get clean data and we can rely upon the result. The other good thing is, because it's not company-sponsored, no one can blame us for inherent bias. So this is truly a not-for-profit enterprise. So the selection criteria for entry into the riluzole study is that the potential participant has to be adult age, between 18 and 75, and they need to present to the treating unit within 12 hours of their spinal cord injury, and they need to get that first dose within that 12 hours. The severity grades are A, B, and C, and I'll expand on that in a little bit. And the neurological levels that we would like to treat are from C4 to C8, and again I'll expand on that. So Professor Dunlop mentioned briefly the Asia impairment scales of severity of spinal cord injury. A is the worst, where there is no function below the level of injury, and E is theoretically normal, but to be E you have to have once been A, B, C or D. So A is the most severe, B and C are sensory and motor sparing to some extent, and you might call them a moderate injury in relative terms. But if you treat someone with an A, B or C type injury, you can track their improvement, because in theory they can go from A to B to C to D. If you take a person who's initially D, which is relatively mild, they actually, surprisingly, very few of them jump to E. So if you look at the graphs, not many people actually go from D to E in any circumstance. So there's a ceiling effect on D. Therefore, if we include Ds in our study, we may be biasing the results the wrong way because we're trying to push through a ceiling that we don't understand. So the Ds have been excluded from the study. In terms of levels, C4 to C8 has been chosen because, again, we can track improvement. Now, the very important thing in cervical spinal cord level injury is if people have improved in their function and gain segments lower down, they will regain function more further out in their upper limb towards their hand. And of course that makes a big difference in practical terms. If somebody initially is a C4 level, I should backtrack a little bit. In the Asia scoring system that we have, which is worldwide and well accepted and as a standard method, the motor levels which are tested are C5 to T1 in the upper limb, and there's some others in the lower limb. So they're the ones where you can actually clinically test motor function, you know, elbow movement, shoulder movement, fingers and so on. That's easily tested clinically. The reason why we don't include the T1s is if they're going to improve a segment downwards to T2, we have no clinical way of determining that, if they've improved to T2. And it would be remarkable that they'd ever improve so much to get down to L2. So the floor effect on T1, we don't include them. We can include C4 though, which is a sensory determination, because if they improve one level to C5, we can actually test that clinically, that's shoulder movement. So that's why we include C4s. And I think Professor Fehlings chose the cervical spinal level to include in this study from his experience with his Staskis trial that was alluded to earlier, which was an observational study of how people did with early, less than 24 hours, surgical decompression. And they found that really the sweet spot for determining recovery in spinal cord function is at the cervical spine level, more so than the thoracic or thoracolumbar, which often involves higher levels of trauma and is often associated with other system injuries to the individual. So, back to riluzole. We screen people before they give their consent. No one who's pregnant can be included. There are a few number of drugs which have to be accounted for, and if they're on their particular drug, they either have to stop that drug or can't be included. We've talked about determining their spinal cord injury grade and level. If you've got such severe peripheral trauma we can't test them neurologically, then of course we can't include them. It includes brain injury too if they can't cooperate, and they need to be able to give consent. In New South Wales, we've obtained permission from the Civil and Administrative Tribunal to take consent from a person responsible if the participant themselves is unable to give their consent directly. Once the patient has consented to be included, they will then actually be then assessed neurologically in detail. It's that detailed neurological examination is actually a study process, not normally part of clinical process. That's why they have to give their consent first. And we determine then if they are C4 to C8, Asia A, B or C. If they fit the criteria, they will be enrolled and we will randomise them to the riluzole tablet or the placebo tablet and give it to them within 12 hours. And we can crush it to give down a nasogastric tube if needed. So the baseline testing is a neurological study, as you might imagine. We've got to document their other injuries and record their past medical history and all their blood parameters. And that's been shown to you before. That just shows you how detailed the neurological examination is in spinal cord injury. And we pay a specially trained physiotherapist to do our examinations for us. And it takes at least an hour or sometimes 2 hours to do a proper and full examination. But it has to be done. Once they've included in the study, other care is as per usual, whether they have admission to the spinal cord injury unit, which obviously they usually do, need an MRI or not, or surgery or not, that's all part of general clinical, usual clinical practice and not dictated by the study. And the outcome, its principal outcome is the change in motor score, adding up the power of each muscle group at 6 months compared with baseline. Secondary outcome measures is a change in spinal cord injury grade, which is nice to know, but actually changing grade is a very crude and inaccurate way of determining recovery of neurological function. And there are other tests of actual practical daily function in the SCIM, which is a record of independence, and GRASP, which monitors practical use of the upper limb. What are the realistic expectations from this study? I don't think this is going to be a wonder drug, but there may be gains at the margins. In terms of spinal cord injury at the cervical level in the neck, if we can improve the amount of functional recovery in the hands, say, then I think that will be some practical improvements for participants, rather than being a wonder drug to cure all. So my journey in getting to this point, and we have started enrolling participants, is that as far back as April 2013 I was approached by Professor Fehlings to see if Sydney could in fact participate in the study. It took them about 8 months to reply to my initial submission outlining how many patients we could possibly submit for them. And once they said yes, I had to scrabble around and start from scratch because I had no research assistant, no pharmacist, and actually no background in clinical research apart from an interest in patient outcomes. So the Spinal Cord Injury Network were very material in introducing me to the right people, and lo and behold I found people right on my own doorstep, and with some initial seed funding from the Spinal Cord Injury Network I was able to enrol a professional who knew about all this, Suzanne Ryan, to help me set up the process by which we could start to run the study. So that was very key to getting this going. We have had some collaboration with the University of New South Wales. The next step was writing out our ethics, National Ethical Application Form, which is a monumental task, and Catherine Bourgeois, who is associated with the Spinal Cord Injury Network, was very helpful in getting that going. PPP have designed and made the placebo drug for us, and I've been able to re-engineer some appointments at my hospital to create a research assistant, which is the envy of many. Then the next thing to do is establish an agreement with AO Spine North America and our institution here in Australia, that we're going to basically play by the rules and provide them the data they want, uncontaminated, and not run off and write our own paper out of it and steal their thunder. So that's all very legalistic, but it's actually crucial. And I discovered that there are international standards for these agreements and there are Australian standards, and we forced the North Americans to use the Australian one after a bit of argy-bargy. So that was AO Spine boxed in the corner. They wrote a clinical trials agreement with Neuroscience Research Australia, and we now have all the subsidiaries joined up onto Neuroscience. And in Sydney it's Prince of Wales North Shore and Royal Rehab, because they will be housing some of these participants in the rehab phase whilst they're still in the study. And then you have a site-specific agreement with your hospitals, so you have to promise to the hospital that you're going to do this in an ethical way and you're not going to ruin the reputation of the hospital by killing lots of people or maiming them or creating bad press in some way, or breaking the rules of clinical studies. So that was all settled. Then you need to notify the TGA by a clinical trials notification that you're using riluzole for a use that it's not actually intended for. That actually only takes about 2 days for them to say yes. And that's the final step, actually. So that then finished in March 2015, 2 years later. But it's now up and going. So these are our sites in Australia so far. There's myself at Prince of Wales. Jonathan Ball is the principal investigator at Royal North Shore Hospital. And at Royal Rehab, Gerard Webber. Suzanne Ryan still provides a lot of background support and input for us. And at Royal Adelaide Hospital is now Brian Freeman, who's just getting the study up and running there. Currently in Sydney, we have enrolled 8 participants in the last 8 months, 5 at Prince of Wales Hospital and 3 at Royal North Shore. Just to put that in perspective, in the same time, there's been a total admission of 28 traumatic cervical spinal cord injuries, and we couldn't enrol 14 of them because of time window. That's the 12 hours, and it's quite hard to get a patient into the spinal unit within that 12-hour time frame. One was out of age, a few were age at Ds and therefore could not be included, and one wasn't included because of inadequate neurological assessment. And that actually is one of the one thing we can do something about, but it's actually very hard to get a decent Asia-type score when the patient is first admitted to hospital. It's hard work, and I have to train my trainees about a slightly modified Asia scoring method so they can do it there in the emergency department. And therefore I think we may have missed one opportunity out of 28 so far. And out of interest, the last few months have been quite quiet in Sydney, both at my hospital and at North Shore. We haven't seen a lot of work in the last 3 months, which I think is a good thing, though I worry that it means there'll be a surge over summer. And these are our participants so far. You can see they track, I think, more or less according to natural history. A couple haven't done so well. This chap actually ascended in level, but there was one that was doing reasonably well, went from B up to D, so C6 to C7 to Asia, D. One person withdrew, and it is their right. That was an elder lady who was really very disabled with a very supportive family, and I think they just wanted to put a barrier around her and look after her themselves, and they were very polite but said they didn't want any more involvement. And it's true, the Asia exam is a very intensive exam. It takes 2 hours to do, and so it is quite an ordeal for some people. One chap died about 4 days after admission. He was a horse rider from the Snowy Mountains who had an injury off his horse, and he was fully with it, had a single system injury, and he flatly refused intervention of any kind because he couldn't bear life in his current state, and in truth there was little prospect of him improving. And he refused intubation when he had respiratory failure and he died. So I think the opportunities that come with doing this study are not just the scientific ones, which potentially I hope are going to be very useful, but for myself, introducing myself to the clinical trials and research area, and hope to do some more. In Sydney, it's nice to harmonise the two units at Prince of Wales and North Shore Hospital, which traditionally, although only separated by 8 kilometres, have never spoken with one another, have never compared notes. We don't have common guidelines on simple things like DVT prophylaxis. The surgeons all used to hate each other, but now there's some discourse. I go over there and they recognise me and they smile, and they see that I haven't got big green horns coming out of my head. And I come from south of the harbour, so my IQ must be 10% less. So we can improve our quality of care by bringing our two units closer together. So I think that's a practical outcome of becoming involved in this kind of work, where they're all working towards a common purpose. And instituting the processes to conduct the study properly means you have to really look at yourself very hard and realise that you need to do a few things better. And of course it's wonderful for Sydney and Australia to be involved in an international collaboration, which one day will produce a result. And I guess it doesn't really matter if it's a positive or a negative result, it's information. And we'll know once and for all whether Riluzole, anything like it, may or may not work. And actually, even if it's negative, we'll know that this kind of study can be done, and that we could do something else with another agent or intervention and know that we could succeed at it. So that's it. Thank you very much.